Welcome back to part 2 of our lectures on healthcare. In the first part, we learned about Tommy Douglas, widely considered the father of universal healthcare in Canada. In this part of the lecture, we examine how this system came to be, how it operates today, and begin to try to understand how Canadians have come to so closely associate healthcare with a sense of who they are, the link between healthcare and national identity, in other words. While today Canadians take for granted that we can visit a doctor or be hospitalized for an operation and not have to pay fees for this, it's important to remember that this was not always the case. Certainly before the 1950s, in much of Canada, families could face difficult decisions, choosing between financial ruin and seeking medical treatment, especially if someone became catastrophically ill. Remember from the first part of the lecture that Tommy Douglas's family was faced with such a dilemma, coming close to having to have their son's leg amputated as a more cost-effective treatment choice. But even lesser problems often raised similar economic concerns. This brings me to a story from my own family's experience. Let me introduce you to Granny Spooner, my great-grandmother. She was still alive when I was a little kid, and I can distinctly remember her sitting in a corner of my grandparents' kitchen, wearing 2 layers of dresses, so that one could be quickly removed to reveal a cleaner one if company arrived unexpectedly. I don't remember that ever happening, but that was the idea anyway. Yes, she was a little eccentric. In fact, she was something of a legend around town. When my great-grandfather died at an early age, she was left to raise her children on her own and spent much of her life in poverty. In her later years, she was estranged from her kids, and she lived alone in a trailer that she had actually parked on municipal land in a park, squatting, in other words. In the colorful language of my family, she was built like a brick shithouse. Short and stocky, she was strong as a horse. She cut her own wood to keep the trailer wood stove burning in the winter. No doubt, town authorities probably thought it best to leave this axe-wielding senior well enough alone. No one really wanted to mess with Granny Spooner, to be honest. Eventually, she was very reluctantly coaxed into leaving the trailer to live with my grandparents. One day, as she was getting out of a car, she caught her hand in the door, nearly severing her thumb. Much to the dismay of everyone else, she refused all medical care. She tended to her own hand, rather than face the threat of having to pay good money for a doctor to fix it. By then, there was universal Medicare in Canada, but Granny Spooner would hear none of it. She didn't believe it. In fact, she lived almost her entire life without ever seeing a doctor until she was quite elderly, by which point she was suffering from dementia and didn't really know the doctors were actually caring for her. The reason I tell this story is because I think it's helpful to remind us just how recent an innovation universal health care in Canada really is. I have, in living memory, grandparents who remember a very different time when the financial consequences of ill health or accidents were often uppermost in the mind. The economics of healthcare could lead, more often than not, to really difficult decisions. So how did we come in Canada to such a fundamental shift in our thinking about healthcare and how it should be delivered in this country? British Columbia and Saskatchewan were the first provinces to provide public universal hospital insurance plans. Alberta and Newfoundland provided partial coverage. By the late 1950s, the federal government in Ottawa offered to share the cost of a Canada-wide hospital plan on the condition that a majority of the provinces took part in it, and that also a majority of the population in Canada would be covered by it. By 1961, all provinces had hospital plans in place, and 99% of the population was covered. Tommy Douglas's initiative in Saskatchewan was then the first also to provide insurance for medical services, or Medicare, such as visits to doctors, who were required then to collect their fees solely from the government. In 1964, Justice Emmett Hall, chairman of a Royal Commission on Health Services, issued a report calling for Medicare for all of Canada. The Liberal government of Lester Pearson subsequently promised that Canada would have a federal Medicare program by 1967, a promise that was in fact kept. By 1972, all the provinces and territories had joined the national
Just
plan.
reading about people accidentally
While
cutting
the
their
plan
vaginas
that
while
emerged
shaving.
is national in scope,
I did that.
it's important to recognize that there is still variation between provinces. For example, some provinces cover visits to a chiropractor or an optometrist. Some cover prescription drug costs for certain groups. Today, Medicare in Canada is governed by the Canada Health Act, adopted by the government of Pierre Trudeau in 1984. It sets out the fundamental criteria or conditions that provincial and territorial health plans must meet in order to receive federal funding. This funding comes in the form of what are known as transfer payments, and in the case of healthcare funding, specifically the Canada Health Transfer. The first of the conditions for funding is public administration. This requires that health insurance be administered by a public authority and on a non-profit basis. This limits the ability of private companies to provide services that normally would be covered by public insurance, but does leave room for private interests to provide non-insured services or to serve non-insured persons. The
Lewis
second
is saying I should
condition
tell Luca.
is comprehensiveness. The provincial and territorial plans
Yeah.
must cover
Thomas, what did
all
you tell
insured
Lewis?
health services that are
I
provided
told him
by
exactly what
hospitals,
happened and how I
medical
haven't given Luca an
practitioners,
answer
or
as to why I
dentists.
wanted
With
to.
respect
But like,
to
did you tell him
dentists,
why?
this provision is limited to surgical
Lewis
dental
knows why.
services that they have to be provided in a hospital.
Lewis
Most
knows the
Canadians
reason.
pay dental expenses privately or through private insurance if they have it.
He's saying I should message Luca
Universality
and tell
is the
Luca.
third condition that plans must meet. All insured persons must be covered for the insured health services provided by a plan under uniform or consistent terms and conditions. Because the various plans are established and operated
I'm
by
gonna
the
get some
province,
water and then I'm
another
gonna
condition
come up with a
set by
response.
the federal government is portability. This essentially provides coverage for Canadians from one province or
You wanna help
territory
me come up
while
with
they
a
may be
response? Or should I just
temporarily
come up?
in another part of the country.
One sec.
A final important or key condition is accessibility. The provincial and territorial plans must provide for reasonable access to insured services by insured persons in a uniform way. This provision helps to ensure that patients can't be denied service on the basis of their age, health status, or financial circumstances. Ottawa also uses this provision to really limit any possibility of extra billing or user charges. The Canadian healthcare system does face a number of challenges. International trade, for instance, can complicate matters. Canada's international trade agreements, most especially the North American Free Trade Agreement, NAFTA, and the General Agreement on Trade and Services,
You
or
can add
GATT,
stuff and I can eat on
could
to me.
challenge Canada's system of national health care. For example, a group of 200 private investors, led by an Arizona businessman, have attempted to use the legal trade remedies under NAFTA to counter what they say have been anti-American roadblocks,
I'm gonna get
preventing
water
the
and then
opening
response.
of a private surgical center in British Columbia, similar to one that was owned by a Canadian physician. Financial sustainability is another challenge faced by Canadian healthcare. Clearly, there is concern over the rising costs of healthcare. We can certainly see that the costs of healthcare provision in Canada have risen consistently year after year. But we do need to be careful not to simply conclude that this suggests that the healthcare system as it is financially unsustainable. For instance, it's problematic to look at healthcare costs only as a percentage of total provincial expenses, as is typically done by those trying to make the argument that the system is unsustainable. To give a specific provincial example, starting in 1988, the share of Ontario's expenditures devoted to healthcare actually decreased for almost 10 years. It was only after 1997 that the share began to grow, but the increase was due in large part to three factors. First, there were significant reductions in spending on non-health related items. Second, there were tax cuts. And third, there were reductions in transfers from the federal government. On this issue of sustainability, another important point must be made. If healthcare expenses begin to seriously hurt a government's ability to spend on non-health related expenses, then we should indeed worry. But real per capita economic output continues to grow, despite shorter term or cyclical economic difficulties that do arise from time to time. So we should be able to expect that the amount of money left for non-health related spending will continue to increase. Federalism is one final challenge that faces Canadian healthcare.
Ooh, that's good.
So this has been a challenge from the very beginning. What we have to remember is that under the Canadian Constitution, it is the provincial governments that are responsible for the delivery of much of what we would consider healthcare. This raises two important points.
Okay.
First, if there are to be national standards to ensure equality of care across the country, then the federal government must be engaged in at least the financing of healthcare, even if the delivery of services continues to remain well within provincial jurisdiction. Second, the federal government has much greater powers and ability to generate revenue. Just check out your pay stub and compare the federal and provincial tax deductions. I bet you're paying far more to Ottawa. The federal government should then play a role in monetary transfers to the provinces, but needs to do it in a spirit of true cooperation if healthcare is to be managed well from both national and provincial/territorial perspectives. To conclude this part of the lecture, I'd like to just briefly touch on the relationship between healthcare and the Canadian identity. There's no doubt that healthcare is an important element of the Canadian
I
identity.
really know.
In part, this comes from a tendency to define who we are by emphasizing who we are not, by pointing out our distinctiveness, in other words. The political idea of community is especially important here. And a former Canadian Foreign Minister, Lloyd Axworthy, put it this way in a speech that he delivered. The principle
I feel
of
like it's so
universal
late to
access
say something
based
now.
on
That's why I
mental
don't know.
needs rather than on ability to pay
Lewis is actually still
both
I
to our sense
know.
of fairness
I know,
and
and
to
I
our
know what
sense
he
of
means,
community.
but like, what the heck?
Canadians have accepted a vision of social justice
Hey,
that
I'm
sees
sending
healthcare
to
as a fundamental
run it by a
human
bunch of people
right.
before sending it.
Within this tradition,
Hey, I know
every
it's been a
citizen,
bit,
regardless
and,
of
I should have
ability to
responded
pay,
like a week ago.
is
But
viewed as
basically,
part
I
of the
decided
same
that I wanted
social
to stay
community.
friends.
This brings us back to Tommy Douglas. Canadians like to perceive their country as a just society. We imagine ourselves as kinder, gentler, more fair, equal-minded, compassionate, and humanitarian. All very much in the democratic socialist spirit of Tommy Douglas. This does raise questions, though. Are we really kinder, gentler, more fair, and equal-minded? Relative to whom? That last question, relative to whom, particularly leads us into the next part of the lecture, when we will discuss healthcare and its reform in the United States. That's it for part 2, though. We'll see you in part 3. Bye for now.